Okay, so it's just about 4:05 on my clock, so we're going to make a start. So I'm just going to do a brief introduction, then I'm going to hand over to Pete, a colleague of mine, who will take us through the rest of the session. So for those of you that are joining this webinar for the first time, we're running a series of safer webinars over 5 weeks. We're doing the A of the bundle today. We've got another 3 webinars to go, same time each week, 4 till 5 on a Wednesday. You can use the same links that you've used to join today. We're probably going to run another 1 or 2 webinars at the end afterwards, just with a few things that people have mentioned. So I'm going to hand over to my colleague Pete in just a moment. I'm just going to say, so I will be your admin person in the background. We'll have a bit of a clinical conversation for the next kind of 30, 40 minutes or so. If you've got any questions for Pete or Richard or Nick or anyone else in the call, pop them in the chat and we'll pick them up later. Or equally, if you want to ask it yourself, just let us know that you've got a question, and we'll spend the final 10 to 15 minutes going through it. There's a few of you that might need to jump away at some point. That's fine, don't worry. We'll send a copy out of the recording and all of the documents and information that we talk about today. That will come around to you all probably by about tomorrow lunchtime. So over to you, Pete.
Thank you, Spencer, and welcome everybody. So hello, my name's Pete Gordon. I'm Head of Emergency Care Improvement with ECIST, the Emergency Care Improvement Support Team. And I'm joined today by 2 of our brilliant clinical colleagues, Richard Genever and Nick Roper. So what the plan is I'm just going to run through a few slides, a quick overview, and then Richard, Nick and myself and maybe a few others are going to have a conversation. So today we're focusing on the A of the bundle, and that is that all patients have a plan, including the expected date of discharge and clinical criteria for discharge. I mentioned this last week, but I'll mention it again. So when I created the Safer Patient Flow bundle, I didn't create it to be performance managed. It's something which is developed grassroots up. Really important message. Don't try and performance manage the Safer Patient Flow bundle because it won't work. Where did it originate from? Well, I was working in an acute trust and ECIST visited and Dr. Ian Sturgis visited, and I found the whole thing quite inspiring, and it took me back to my experience of being a senior critical care nurse and using clinical care bundles, particularly the ventilator care bundle. And what I found was that, you know, with clinical care bundles, they reduce variation and encourage standardization. So it's not based, wasn't created in a meeting room. It started off in an acute trust, and then when I came to ECIST, I refined it a little bit, and that's where SAFER was the genesis of SAFER. So important messages there, don't performance manage it. It came from a fairly straightforward ex-senior nurse based on clinical care bundles. So why is the plan important? Well, this is me, and this is my son, Alfie. And Alfie's 19 years old. He has very complex special needs. He requires 2-to-1 care 24/7. We're just going through the transition now into adult care. But let me tell you, if you're a loved one of someone who's so special and you don't know the plan, and Alfie can't talk, he's non-verbal, he can do a bit of Makaton signing. When you don't know the plan, when he doesn't know what's going to happen now and later today, whether that's using Makaton or pictures, he gets really scared. And as a loved one, when you don't know the plan, you get incredibly worried. So plans are important. And I'm going to start with the patient. You know, 4 questions which were developed by Ian Sturgis that every patient and their loved ones should know. And these don't cost anything, and they should be in the hands of the many. So do I know what is wrong with me or what has been excluded? Do I know what's going to happen now, later today and tomorrow to get me sorted out? What do I need to achieve to get home? Using the term back to baseline is rarely a useful phrase. If my recovery is ideal and there's no unnecessary waiting, when can I expect to go home? The expected date of discharge. So when we think about plans, these are common phrases. And when I'm thinking about this, these are on the medical notes typically, or on the electronic system you use. And these are things that we often see: home when stable, home when mobile, start discharge planning, home after the weekend, medically for discharge and back to baseline, recheck bloods tomorrow. Now, the problem with that is they're common, but they're not really clear. They're not really specific enough. So, you know, an example could be, you know, if you say a patient with pneumonia, rather than saying the patient feels well enough, I've never had pneumonia, but I've looked after plenty of patients with it, and I think it takes you quite a long time to feel well enough. It may be, you know, you have a plan which is a bit more specific. So the clinical criteria for discharge for this patient could be afebrile after for 24 hours, not requiring oxygen for 6 hours, neutrophil count less than it was on admission. So it's more specific, and we're going to get some live plans that Richard and Nick have been using in their clinical practice this week. But as well as clinical criteria, we also need functional criteria as well. So, for example, you know, can this chap who lives on a boat, can he walk up to 10 meters? But the other thing as well is what really matters to the person, to the patient, because sometimes even if we think something's risky, but a patient's willing to accept that risk, if it's been explained to them, the patient should be in a position to decide. And so here's an example of a plan. We're going to show you a couple of other plans shortly. But, you know, treat with oxygen to maintain saturations of 88 to 92%, nebulized bronchodilators, oral prednisolone for follow-up with the acute respiratory service at home team. And here we are, the clinical criteria for discharge: able to maintain saturations without oxygen, which is physiological, able to manage to the toilet, able to mobilize 10 yards, which is functional. And that's what we're talking about here. All patients have a really clear plan that they and their loved ones know about. I'm going to stop presenting the slides there, and I'm going to come to Richard and Nick. And do you want to introduce yourselves? Richard, do you want to introduce yourself first?
Yes, hi, I'm Richard Genever. I am a clinical associate with ECIST. I'm a consultant physician and geriatrician by background, working in Chesterfield.
Brilliant, thanks. Nick?
Good afternoon, I'm Nick Roper. I'm an acute physician in the northeast of England. I'm a clinical director with ECIST.
Brilliant, and I think we may have Ian Sturgis on the call. Are you there, Ian?
Yes, Pete, but I've got very weak Wi-Fi, so hope you can hear me.
Yeah, we can hear you, Ian. Do you just want to briefly introduce yourself?
So yeah, so I'm in Sturgis. I'm supposed to be a retired consultant physician and geriatrician. I helped set up the emergency care intensive support team back in 2009, and I've been a clinical director and medical director, so I've been around a bit.
Yeah, thanks, Ian. We'll bring you in, bearing in mind I'm really aware that where you are at the moment and your Wi-Fi isn't that strong. So first question for Nick and Richard: why is it important for patients to have a clear plan that they and their loved ones know? Let's go to you first, Nick.
Thanks, Pete. I think, as you outlined before, it's a basic expectation, isn't it? And I think as a patient, you would expect it. I think it's also a really important way of just checking you're actually on the right lines with the patient. So if you can't actually articulate what the problem is you're trying to fix back to the patient and then agree with you that is the problem they came in with, it's a really good check that you're actually attempting to fix the right thing. Because I think quite often we start to go off on tangents and lose the point of what's actually important and wrong with the patient. So I think it's, for me, it's a quality check as much as anything.
Brilliant, thanks, Nick. Richard?
Yeah, I'd agree with that. I would say it's really useful as well for preparation and information. So from a preparation point of view, preparing the patient and their family for the fact that they're likely to be discharged at some point in the future, and allowing them to start thinking about that person as somebody who's no longer an inpatient. And that's where things like, you know, dressing people in clothes rather than pajamas is a really important sort of step. So that preparing for that transition back out of hospital. The information bit, quite often if we say, you know, we're expecting your mum to be able to come home in 2 days, it's an opportunity for people to say, but what about the fact that the whole house is flooded, or some other medical issue that we actually were completely unaware of? It gives us a chance to take account of and address issues that we otherwise would have found out on the day of discharge.
Brilliant. Thanks, Richard. I mentioned expected date of discharge. How do you use it in your clinical practice on a day-to-day basis? I'll switch the order now. I'll go to Richard first.
So for me, the expected date of discharge it's the time point at which everything else runs. So an example I often refer to is a wedding invitation. So let's imagine you've been invited to a wedding on Saturday somewhere in rural Somerset. In order to get there in time, you need to work out how you're going to get there. You need to work out the mode of transport you're going to use, and therefore you need to decide when you're going to set off. And if you don't set off at the right time, you're going to miss the I do, and your journey is going to be wasted. But actually, there's other tasks that you could go further back in time for. So probably you need to organise a present before you'd set off. You need to work out if you're working that weekend or not. And so there's certain things that if you haven't done it by a certain time, it's going to be too late. You're not going to physically have the time to achieve the task you need. And the same goes with an expected date of discharge. So if you wait until that person is medically, they've met the criteria for discharge before you start doing things like therapy assessments, if they're necessary, then you're going to guarantee that person's going to be exposed to the risks of being in hospital longer than they need to.
Yeah, thanks, Richard. I really like that analogy of the wedding analogy. Nick, how about you? How do you use expected date of discharge?
I mean, very similar, I think, to what Richard's outlined. I think the other thing we would do here operationally, which is perhaps going slightly left field with it, is use it by the patient flow team on the day, so they're able to see from that morning an updated list of people we expect may be going home today, and once that's been confirmed as definite discharges, which then feeds through into transport requirements, transport booking, saves the going around the wards, just collect information. It's all very, very visible, so you're able to see at a glance where we are with a degree of confidence. So as well as that sort of planning ahead element to it, there's the operational on the day flow bit, that if you've got accurate data coming in from your EDDs, it allows you to act upon that, and I think that helps us a lot operationally.
Yeah, brilliant. Thanks, Nick. I'm just going to give Ian a heads up. I'm coming to clinical criteria for discharge now, Ian. After I've discussed it with Nick and Richard, I'll come to you. So mention clinical criteria for discharge. So maybe starting with you, Nick, is why is it important? And can you give the people listening some examples of functional and physiological criteria, the type of things that you would write in a plan?
Yeah, absolutely. I think I always come back to the Einstein quote: if you can't explain it or write it down simply enough, you don't understand it well enough. So if you've got a really clear idea of what is the problem you're trying to fix and what you need to do to fix it, you should be able to describe easily what that will look like in terms of a functional or physiological outcome. It's that clarity. So I think one I often use as an example is AF. So if someone's come in with AF, they haven't come in saying my problem's AF. They've usually come in either breathless or with chest pain. And yet our criteria, the most common thing you see is home when rate less than 100, which as far as I can work out is picked because it's a nice round number that looks neat on a page. And it doesn't say whether that less than 100 is before they've been to the toilet, after they've been to the toilet, when they've just got dressed, when they've been asleep for 5 hours. By definition, it changes beat to beat, so it is fairly meaningless. So what I would try and do is turn that round to they came in getting breathless or chest pain while they were doing their normal activities. So if they can walk as far as they need to walk without getting breathless or without getting chest pain, then I have fixed the problem they came in with. They can go home. So it'll be home when able to mobilise 100 metres, or often I use the shop at the front of the hospital to the shop and back without getting chest pain, without getting breathless, then they can go home. I don't really care what the rate is. It's can they do what they need to do without getting the symptoms they had when they came into hospital, that then allows them to go home. So keep it about the patient, not about a parameter that makes more sense to us.
Thanks, Nick. Richard?
Yeah, I really like the example of AF. I think there are people up and down the land being kept in for this arbitrary number with rate control. So yes, definitely like that. I would say try and think about, I think there's two reasons to be in hospital. One is that you are very sick and you're too unstable to be anywhere else at the moment. There's imminent risk of death if you were to leave hospital. And the second reason is you're receiving a treatment and you continue to receive a treatment today that cannot be delivered outside a hospital. So think about which of those apply to your patient and try and specify the situation when neither of those things still apply. I think a good way of sort of addressing this is to ask the question, would I admit this person from clinic or from a GP surgery to address the problem we're keeping them in to address? It's very, very easy to fall into the trap of keeping people in hospital for tests. They may be tests for very serious conditions, but they're not tests that you necessarily need to be in hospital for, often kept in for education, monitoring purposes. So really just get to the nub of what is it that requires acute hospital care that's keeping you in here. The other thing I would certainly, this is not directly what you asked, but I think it relates to it, is we often try to manage chronic diseases in hospital, and actually hospitals are the worst place to manage chronic diseases. Successful life around a chronic disease is all about engagement. It's about learning how to use exercise, how to manage yourself, how to access help when you need it. And when we try and manage these conditions within patients, what we do is we move to a sort of firefighting approach. We say that the acute hospital is where all your solutions are. If there's an issue, don't worry about it. Just get sick enough to need to be in hospital, and we'll sort it for you. So basically be mindful that we're not keeping people in hospital longer than we need to because we're trying to sort out something that we can't actually sort in hospital.
Thanks, Richard. Ian, in terms of clinical criteria for discharge, it was a concept you introduced to me many years ago. Sort of your thoughts on it, and maybe, you know, a couple of examples, particularly around the functional stuff, Ian.
Sure. Yeah, I'll turn off my video because that's going to interfere with the Wi-Fi bandwidth. I mean, the crucial thing for me is the combination of the expected date of discharge and the clinical criteria for discharge is the goal of the admission. What are we aiming to achieve? And Richard and Nick have absolutely nailed it. I mean, I love the analogies they've given. I also love the thing about from Nick about creating expectation. You know, so the power goes back to the patient about when I've achieved this, I can leave hospital. It gives the power back to the person. So I mean, the one I frequently use, you know, an older lady, 82, lives at home, carers twice a day. She can normally walk to just outside her front door to the front gate, so it's about 15-20 meters, but a toilet's only 5 meters away. And she comes in with quite significant postural hypotension, a bit of delirium on top of a dementia, and a true UTI, not a dipstick UTI, and a bit of a fever. And the criteria would be, you know, obviously afebrile, reduced symptomatic postural hypertension, not abolished postural hypertension. I run a full service, and most of my outpatients had very significant symptomatic postural hypertension, which we're managing as an outpatient. And then something around function. So, you know, if her toilet is just 8 paces away from her bedroom, then if she can walk 8 paces, she can go home. So it can be as simple as that. I mean, sometimes people overcomplicate clinical criteria for discharge. It's about keeping it as what is the minimum that this person needs to be able to achieve to be able to leave hospital. And Nick's right, you know, is it symptom based, or is it physiological parameter based, or is it functional based? And it usually is a combination of all three if they are particularly people living with frailty.
Okay, thanks, Ian. And should every patient have a clinical criteria for discharge? I'll ask you that one, Ian.
Well, my simple answer is yes. I would find it impossible to look after patients without an EDD and a clinical criteria for discharge, because I wouldn't know what I was aiming to achieve, and I would just find it impossible to look after the patient. So that would be my challenge to everybody: is if you haven't gotten a goal or an objective, how do you know when you're finished doing what you need to be doing? And the analogy I would give is, would you get onto a plane where the pilot says, I don't know where we're going and I don't know how much fuel I've got?
I really wouldn't. I'm quite scared of flying, if I'm being honest with you. That would just make it awful. One of the things that
you're also pretty frightened of me turning corners in a car, if you remember.
I do remember, Ian, in somewhere in mid-Essex that was, and I screamed very in a high-pitched tone. Thank you for reminding me, touche. Just one thing that is asked quite a lot is, so we encourage sites and teams to try and implement clinical criteria for discharge, but how can you get buy-in when people are trying to, you know, get people to write really clear plans, like communicating that? Just maybe a couple of tips, maybe Richard, to how can you encourage, you know, when teams are trying to do it, to get buy-in? But you're on mute, Richard. I think everyone was muted briefly.
I'm back. I'll put something into the swear pot later for being muted. Yeah, so I think it's important to listen to people when they're sort of saying, I find this difficult, because it can be difficult, particularly if you've not been working in this way for a long time. I can't imagine a situation where I couldn't think of what the criteria were for a person, but I guess if you did find it difficult, one tool that kind of helps with that is the News 2 decision support tool. So it's available on the NHS Futures website, and it's on the Fab NHS Stuff website, and it's a series of questions that walk you through from a starting point of what is the early warning score, and if the early warning score is not high, then are there other reasons that keeps that person in hospital, such as oxygen that they can't be weaned off, although you could argue now that actually now that we're opening our eyes to other possibilities, some people who are improving but still needing oxygen might be able to be weaned off in a virtual ward setting. Are they still on a treatment that can only be given in hospital? If the answer to all those things is no, and you would not admit that person from clinic with the problems they've got, then I think you've run out of valid reasons to keep them in hospital. There may be reasons why they can't go back to their normal place of residence. So those often will be functional things, but actually a hospital is probably the worst place for those people to be. So all that applying, you know, clinical criteria for discharge is doing is thinking about those questions in advance. It's imagining what are we doing now that we won't always be doing that will allow this person to leave, and just breaking that down into small manageable chunks without being being specific enough that people understand exactly what's meant, but not painting yourself into a corner that you could never achieve. So perhaps setting oxygen targets that would never be reached, that sort of thing.
Nick, what about you? Just a couple of tips about how do you get buy-in when people are trying to implement clinical criteria for discharge?
Yeah, I mean, I think for me sometimes there's a danger of overcomplicating it. I don't think this is a new concept we're talking about. I think the theme that's coming across here is that it should be just bread and butter of what everybody does. So you're getting a patient in, you're doing an assessment, you're deciding what's wrong with them, what is causing the problem that they've got. You're then articulating how you're going to fix it, which should then lead immediately to, and you'll know it's been fixed because all of these things will have stopped happening. So it's not about having a form or another bit on the ward round to fill in or something extra to do. It's about taking that bit of extra time up front to really just clearly articulate the plan right the way through for what's happening, both in terms of expectations. And I think, you know, one of the examples you quite often see, and when I'm teaching registrars to do it, they have a plan that says do scan, and you're like, well, yeah, and what you're looking for, and there's three outcomes from that. They've either got what you're looking for, they haven't got what you're looking for, they've got something else random in there as well. You can actually make a plan for all of those things. If they've got it, do that. If they haven't got it, do this. If you find something random, phone me. So actually it's just putting that bit of extra time up front so that you clearly articulate and frame what the problem is you're trying to fix. That then becomes obvious when you've fixed it, and that's the point the person can go, as Richard's outlined, or when they're on the road to it being fixed. But if you're that bit of investment up front, then makes life really easy for the next person to inherit it. And I think one of the tests for me is if you give the junior the ward round plan they've just written, and you cover up everything other than the plan, you say, right, that's all you're allowed to read. Do you know what you're doing and why? And if the answer to that's no, it's not a very good plan. So that should tell you everything you're doing, why you're doing it, and how you'll know when you've got what you need to accomplish accomplished. So that's the challenge, is, you know, it's got to be, doesn't need to be long, but it needs to be accurate and clear.
Thanks, Nick. Ian, you've got your hand up.
Yeah, and I'd agree again entirely with what Nick and Richard have said. I just want people to reflect actually on what happened during the COVID surges. People became very good at setting clinical criteria for discharge for patients with COVID, a brand new acute illness that people knew very little about at the beginning, but very quickly learned to set a series of criteria which would allow them to discharge people home, and then obviously discharge people home whilst they were still weaning oxygen and coming off their dexamethasone via virtual wards. So I think what we have to recognise is that people can do it because we've done it for a brand new acute illness that we knew next to nothing about when it first started hitting our shores. And it really is about clinical leadership and supporting each other. And one thing I'm very clear about is peer support and peer review. It's not criticism. It's saying, well, how might you set these criteria? Just using those tricks that Nick and Richard were alluding to there. So I think the COVID analogy is a very beneficial one, because I think the vast majority of people have got used to using clinical criteria for patients with COVID-19. And actually it's about, right, how do we now spread that to the conditions that we've known about for so long already?
Thanks, Ian. We're now going to, I'm going to put on the screen a plan that Nick used on one of his ward rounds earlier on this week, and a plan that Richard used. Just as a heads up, I can see Jyoti's on the call. So Jyoti's one of another ECIST clinician, a consultant from South Warwick, which is also the long length of stay lead. So just as a heads up to Jyoti and Ian, when Nick and Richard have talked through their plans, I'm going to come to you both, and Nick and Richard, to just finish off the session talking about the top tips. I'm just mentioning that to you, Jyoti, so it's not a complete surprise. So I'm going to share my screen again, and Nick, going to look at your plan first. Obviously not to mark homework, but to just talk through people. And there it is.
Thanks. So this was about 8:30 Monday morning, I think it was. So this was a patient with COPD who'd come in overnight. I was seeing her on the post-8 ward round. I just, as I was going in there, seen her walk back from the toilet unaided, off her oxygen. So I actually took her oxygen off at the bedside. So the diagnosis was fairly self-explanatory, I think. The SATs actually came from, we're lucky in terms of we have an EPR, and I could look back at what her SATs were on discharge on her last admission. So the 90% threshold comes from, that's what it was when she went home in May. So that's what we're aiming for on this occasion. We have a very good COPD team in terms of supported discharge, and a hospital at home team who can do NEBS at home on a 2-hour response. Although actually this occasion that was more around follow-up, because what that scheme allows is once someone's been through it once, they can self-refer on subsequent episodes. So even if the patient's relatively well on the discharge on this occasion, they go through that system, next time they can cut the hospital out altogether and just go direct to the hospital home by phoning them directly. The antibiotic steroids and cyclizine were what was required prescription-wise for her discharge, and she was going to go home when she was off O2, which I took off at the bedside, and her SATs remained within parameters at her next set of obs. So I guess I could have been a bit more specific about the time frame there, but there's also a verbal handover to the nurse in the bay around, you know, I've taken her oxygen off, check her SATs. If they're okay, she can go home, and the natural turnaround then time for the prescription would have set that at about 2 hours roughly. So that was a real example from this morning, and something I've done more in the last year, I think. That's taken from the nursing handover element of it, which I've got into the habit of updating myself as I go around. So I'll verbally hand over to the nurse and I update that plan so it says what's there and try and make that effort. Because I think that time invested up front is paid back many times over downstream, because everybody's clear about what's happening and things do happen without delay. And I've spelled antibiotic wrong, I've just noticed.
I'm surprised Tim Gillett didn't mention that. Okay. Thank you, Nick. I'm just going to go to your plan here, Richard.
Thank you very much. Seeing Nick's plan just reminded me that hospitals are brilliant at starting oxygen and really bad at taking it off again. And so actually physically removing somebody's oxygen who doesn't seem to need it is one of the most powerful things you can do, I think, when you're doing a ward review. So this is somebody who was admitted with pneumonia. They had a KERB 65 score of 3 because they'd got new onset confusion, their urea was slightly raised, and they were over 65 years of age. So the plan was to give a combination of intravenous antibiotics, and that is in line with the Trust guidelines, and with a review to review after 48 hours for oral switch. To recheck the UNE the following day, so we're still within 24 hours of the discharge there. We're not at risk of delaying the discharge through doing blood tests. I think one of the things you can really look at if you want to try and improve, particularly time of discharge, is how many tests are we doing on the day of discharge? Do we really need to do those day of discharge tests? I know that that Ian will be about to jump in and say yes, but don't keep people in an extra day in order to not do their blood test the next day. But think about, do we really need to do the test? So the next step is send blood cultures because they'd had some rigors and EED, and then set some criteria for switching to oral antibiotics. So if the news score was 3 or less, nothing started to grow in the blood cultures, there's plenty of time for something to have grown by then. Eating and drinking, taking oral meds. Physiotherapy review, huddles are a good time to say, yes, it's okay to start doing that assessment now. We don't need to wait until they're medically stable, because otherwise there's a risk of things just being pushed on, not medically stable. We'll wait and do the assessment then. So do say, yes, you can do that. Probably the number one situation where I say, yes, please carry on is orthostatic hypotension. Unless it's significantly symptomatic, it absolutely is not a reason to keep people in their beds. In fact, it's probably a reason not to keep people in their beds, so I'd say. Speak to the family about delirium. So I think delirium causes enormous amounts of anxiety about discharge. And I think what you have to get across is that we recognise it. We're not saying that this person is normally like this, but being in hospital is probably going to be one of the ongoing risk factors. And actually getting back to a familiar place is going to help. Giving a leaflet to back that up helps with the authenticity of the message, but also just remembering what we've said. So the criteria for discharge would be UNE no worse tomorrow, oral antibiotics, and then the functional mobile 5 meters with a Zimmer frame. We've established that's the distance they need to cover, and not requiring enhanced support for the delirium. So we're saying that this person can go home if they're still confused, as long as they're not requiring that kind of high level of support because it's a danger to them or others. So you'd give an expected date of discharge of 2 days for this situation.
Great, thanks Nick, and thanks Richard. So just going to go now. So they're really real live examples of good patient plans written by consultants. So I'm just going to go now. I'm probably going to go in this order: Jyoti, Ian, Richard, Nick. Just for people listening in, top tips about how you really get teams to create clear plans and ensure they're communicated to patients and their loved ones. So Jyoti, are you there?
Yes, I'm there actually, yeah.
Hi Jyoti. So what are your top tips?
For writing clear plans, I think we really need to go back to the things which Nick and Richard said in the very beginning. You really need to look at what actually brought them to the hospital. What is the, why are they here? Yes, they have lots of problems, but why are they here in an acute bed, and how you can sort it out? Unless that question is very clear and that answer is clear in your head. And exactly what does the patient want to be able to go back? So if these two things are lined up, you have your answers. So that would be, for me, the top tip. Think of what brought the patient to the hospital. So yes, you got lots of things, but on this occasion, why did you come? If you ask that question, perhaps it'll give you the reasons, it'll give you a list of things that you need to do for them to go home.
Brilliant. Thanks, Jyoti. Ian, what's your top tips around for the people who are listening in around having really good plans and getting ensuring they're communicating out to patients and their loved ones?
Yeah, I mean, I'll absolutely agree with what everybody just said before, and the two plans that we've seen. It's, fix what's brought somebody to hospital, keep it simple, make sure they are very clear criteria, not woolly criteria. So as you saw in your very first slide, it's about giving a distance, not saying independently mobile or back to baseline. You know, that is not helpful. So it's what is the minimum somebody requires to be able to do to be able to go home that reassures you that you are on the right journey of recovery for that acute presentation that brought them into hospital. And I think it's particularly important to reflect what Richard said around delirium. Mild delirium is much better managed at home than being in hospital. If you want to convert incident delirium to persistent delirium, keep somebody in hospital and move them twice without a clear plan, and then you'll have persistent delirium and a very long length of stay. So my top tip would be keep it simple and fix what needs to be fixed in an acute hospital, but obviously have a plan. If there are other things that need to be fixed on a long-term basis, that's a plan for outpatients or community-based services.
Thanks, Ian. I can't remember the order I said now, so I'm just going to make it up. Richard.
Just to expand a bit further on the delirium thing, I always think of keeping somebody in hospital because they're confused is a bit like leaving an ice cream out in the sun because it's melting. So it's probably the source of the problem, and until we kind of address that and say, look, we could be making things worse here, we accept there's an issue, how are we going to make it as safe as possible? You're going to just keep that person longer and longer, and as Ian said, make things a lot worse. So top tips would be, yes, I agree, be very specific, particularly with the functional stuff. I think that is just as important as the clinical stuff. But think a little bit about how you define some of the clinical things, because sometimes you can actually create problems by being specific in the wrong way. So to give an example, if somebody's got low sodium and their sodium levels are currently 120, and you say they can go home when their sodium is 125 and it comes back as 124, then people might just keep that person in hospital. Whereas when you're having that discussion, they said, what if it comes back 124? So well, obviously 124 would be fine. So would we set it as 124? And then what about if it's 123? So think about smart ways to define what sufficient improvement would look like. So it might be something like sodium rising or sodium no lower than today. It depends on the situation, but just think, am I potentially creating a problem? Percentage rises might be better than specific figures, because then people are more likely to look at it as a ballpark thing. But I think the line, if in doubt, check with me, is the sort of safety net. And I think be open with people about the risks and benefits of being in hospital. I think one of the issues that we all face is we're all engaged in what you might call caring professions, and sometimes the decision to discharge somebody can seem like a harsh decision or a decision that lacks empathy. And in fact, what we have to do is we're saying it's not about that. It's about, we know that the most dangerous place to be for a particular person living with frailty is an acute hospital. And what we're looking for is the right dose of hospital time and what the options are to get that person the treatment they need, the possibly rehabilitation they need, but outside of that hospital setting.
Thanks, Richard. And Nick, your sort of top tips?
Going last always increases the pressure, doesn't it? I think two things probably. One is if you're not sure, ask an explicit expectation. I often say to juniors, I don't mind if you make a decision to do something, but if you've got a question and you don't ask me and I come back tomorrow and find you've not asked something I could have told you yesterday, then that's something I think is unacceptable. If you've got a question, I have a phone me, ask the question. I don't want to come back tomorrow and find you waited 12 hours to do that. So make that an explicit expectation that if you don't know what to do, phone me. And I think the other thing is make sure you keep it about the patient, not about us, both in terms of how you're framing your expectations and framing the risks, and in terms of the outcome desired. So, medics are inherently curious beasts, and there are times when that curiosity gets the better of us, and patients end up going through stuff because we're trying to work out what's wrong with them. The problem they may have fixed may have got better. I think pain's a very good example of that. You see two extremes. So someone comes in with pain, and we spend ages trying to work out what's wrong with them, and you find no one's actually given them any pain relief, and that's why they came in the first place. Or it's got better, and we're still obsessing about why they had it in the first place. And the patient sort of that thing, I'm better now, can I go please? And you go, no, I don't know what was wrong with you. You know, so it's not about us, it's about them, and make sure you keep that message. I think that goes back again to the clinical engagement stuff. Clinicians, by and large, are in this for the patients. And if you reframe that back at them, then I think most people will respond to that. I think sometimes it's not malicious that people lose sight of that. It's just human nature sometimes. I think just pulling them back to, yeah, I know it's very curious and very interesting what's going on, but actually the patient that sat over there doesn't want to be here. What they came in with has gone. Let them go. You can bring them back to your clinic if you're that interested, but let them go.
Great, thanks, Nick. So that's our sort of conversation coming. Oh, Ian.
Hi, Pete. Yeah, there's a great question from Minia Jones from Hywel around risk thresholds and how we might manage that. And I think it's a really valid question. So one of the things that I ask people is, do we understand what might have occurred to a clinician that might have altered their risk threshold? So if you've suffered from multiple complaints around the term failed discharge, and I think the term failed discharge should be banned universally. Failed discharge actually means inability of the system to maintain somebody at home, and every discharge is always a balanced risk. So failed discharge and people putting in instant forms around discharges actually creates risk-averse behaviour. So we need to understand that. I think we also need to understand clinical leadership is really crucial in supporting people making decisions, and peer review is a very strong way of providing that clinical leadership and support for individuals. And peers should also be GPs. We don't, sometimes as hospital doctors, we don't fully understand what level of risk and illness severity people are being managed out in the community. And we need to share that across the system in a no blame way. But as soon as people start blaming each other about a discharge and using the term failed discharge, that's what starts having an impact on people's risk averse behaviour. So ban the phrase failed discharge. It is inability of the system to maintain somebody at home.
Thanks, Ian. So key, very clear message there from me, Ian. Ban the phrase failed discharge. So I think there's a few questions in the chat box. I'm going to finish it there and hand over to Spencer, but I would just like to say it's great to see so many familiar names and faces on here, and a particular shout out to the people from Hywel Dda, our Welsh colleagues across the border. So Spencer, I'm going to hand back over to you.
Cheers, Pete. There's only one other question, but before I forget that, the conversation we just had around engaging GPs and how do you, as a trust, as a system, come together to start shifting perceptions and shifting risk. When we do the R of the bundle, so that's 3 weeks time, I think on the 21st, we've got a GP that will be joining along with a community geriatrician in the same patch to talk about how you can maybe restructure some patient reviews to start, I suppose, flattening that system hierarchy and start building some of those system relationships. So that might be a good one to join. But the question that came up was around how do you, and this is a question to all of our medics, around how do you provide the medical leadership to tackle some of that clinical variation around, you will have clinicians who really get clinical criteria for discharge and do it really well, and there'll be others who either don't get it or don't believe in it or don't do it or don't write it down or any one of those things. How would you approach that kind of situation? How do you bring them along with you?
Shall I come in on that? Yeah, gosh, it is it is a difficult problem. So I think none of us is perfect, and we all work in places where there is variation. I think it's important to say. So I think that if you can develop ideas along with people, that often helps them to kind of come along with it. So so I'm very fortunate that the colleagues I share a ward with we are so closely aligned in terms of our sort of approach to things that it makes no difference which of the three of us would see a patient. We would entirely trust the other two to make decisions that we'd be happy with. So I guess if that would be a good test of alignment, is how happy would you be for your colleagues that work in the same area to look after your patients for you, without wanting to sort of blow the News 2 decision support tool trumpet too much. It is a thing that you could try people with, because it's objective and tries to bring a bit of similarity of decision making without forcing people into following strict guidelines. There's plenty of room for clinical variation where you've got particular specialist area or something like that, but it can help to bring that together. I'll hand over to Nick, who's got his hand up.
Thanks. I think I'm going to agree with the variations there, and it's always going to be there. Some people are going to be more risk averse than others. That's just a fact of life, isn't it? My impression is that there's probably more delay in lack of clarity than there is in clear but risk averse. And I think if we can just get everyone to be really clear about what their plan actually is, there is far more bang for your buck in that than there is trying to get the risk averse person to be a bit less risk averse. So I think going for the clarity is the thing. And if you start with, you'll be a few early adopters, get them on board, start to use the different bits around the patient focus element to get a few more people on board. You will start to build an expectation to the nurses, the junior medical staff. As more people do it, we'll start to expect it of other people, and that will draw other people into it. So I've got risk averse colleagues who now will see people on our assessment unit direct from their ED clerking. If I'd sat down and asked them to do that, would have had kittens and argued about it till the cows came home. So we didn't. We just started doing it, and it became an expectation. And it became an expectation that they didn't, or very, very rarely would go, actually, I'm not comfortable with this, I'm not going to do it. They would just go along with the pack, essentially. We are pack animals still. If you get the majority of the pack doing it, the rest of the laggards will follow. But I think, going back to the start, clarity is the really important thing. Risk aversion, yes, important, but I think is much less material to the whole spectrum of delay.
Thanks, Nick. Richard, have you got your hand up? Is that a new hand or?
Yeah, it just reminded me of another idea actually to try and sort of bring people on board, which is doing 1 or 2 case note reviews. I'd recommend looking at people that have been in hospital for 3 or 4 weeks, because in amongst those you will very, very quickly come across people that had relatively little going on from a medical point of view at the beginning, and something will have happened and they've reached a threshold where all of a sudden they convert into a long time in hospital, usually to no advantage to them. And that's a good way of just getting people to stop and think, oh yes, actually this is a problem. And I completely agree with what Nick said about where you get the most bang for your buck. It's because I think people who are reluctant to engage with this think it's about kicking people out of hospital when they're still sick, and it's not. It's about recognizing that there may be a very small window of opportunity to get somebody out of hospital before they succumb to a hospital-acquired problem. And that's not just infection, because that allows us to think, well, when COVID is gone, we're off the hook. We can keep people as long as they want. Actually, there were hospital-acquired harms long before COVID was even thought about. So it's, yeah, I'd agree that it's if you can be specific and clear and efficient, then you can help to avoid those harms. And I would just, one final thing is, in fact I go as far as to say I try not to use the term risk averse, because it kind of says that there isn't risk in keeping the person in hospital. So I sort of use this term risk blind, that you're not actually aware of where the real risk might be. I've whistled on too long.
No, that's fine. Thank you, Richard. So one thing that we briefly touched on this last week as well, about how you manage some of these things. And one of the things that we talked about last week was a lot of the perceived difficult conversations are because we shy away from them. And there's something about the standard that we will pass is the standard that we accept. So I think, you know, clinical variation happens everywhere. So there's something about having that conversation without any specificity, but just beginning to put it on the table about how do we start to talk about our individual variation and how does that impact ourselves, our teams and our patients. And there's certainly something there about the consistency in which you do it. If it's done really randomly or after an SI or after something's gone wrong, people will feel attacked, they will become defensive and the conversation won't go anywhere. So there's something about how do you start to consistently have that conversation to bring down defenses. When I send around the kind of the summary of this session, there's also, if you are interested, there is a place in America called Intermountain Healthcare, and a big part of their improvement journey is focused on tackling unwarranted variation in all processes, whether that is a pure process variation through surgical variations all the way through to, you know, anything and everything there. There's a really good video somewhere. I'll see if I can find it and I'll drop that in as well. But that leads me on really nicely. So it's 5 to 5 now. So this is the end of today's webinar. So I just want to say thank you to everyone who has contributed. So thank you to our speakers, thank you to Nick and Richard, thank you to Ian, thank you to Pete for facilitating that conversation. Thank you all for joining and listening. We genuinely hope you found it interesting, found it helpful. What we'll do probably by about tomorrow lunchtime or so, don't hold me to that time, that might be the end of the day, we'll send around a recording of the webinar. We'll send a copy of the News 2 tool, the Intermountain clinical variation stuff, if I can find it. If you have enjoyed today, like I said earlier, we've got another 3 of these webinars running every Wednesday, 4 to 5 for the next 3 weeks. You're more than welcome to join. You don't need to sign up for another one. You can just join again next week. It's exactly the same link. But I hope you found it helpful, and I'm sure I'll speak to a lot of you again soon. So enjoy your evening. Thank you very much.